Okay, I think we'll get started. Thank you to everyone for coming. Before we start the session, I just want to say a couple of words. Apparently, I didn't realize this, but there has been a subway delay that many of you may have experienced. If you did miss part or all of this morning's session, I just want to reassure you that the slides will be made available. You'll receive a notification in the next little while, and the slides will be made available to you. And I'm sorry if you did miss that. I'd also like to start by thanking the team that put together this session. It's all about personalized reports for driving quality improvement in primary care, or audit and feedback. And I'd like to thank Gail Dobell, Wissam Haj Ali, Rachel Froelich, Dave Zago, and Stacy Johnson for all the work that went into organizing the speakers and the presentations that you'll hear today. My name is Anna Greenberg, and I'm Vice President of Health System Performance at Health Quality Ontario. So we're here to do a couple of things today. The first is to gain an understanding of the use of various tools that are available to primary care providers to support quality improvement within their practices. And many of you in the room may have been involved in some of the initiatives that are available. And then the second here is to have a discussion, as it says here, about potential coordination and alignment of the initiatives that you'll hear about. And I think that we should push this a little bit further. For those of you who had the opportunity to hear Dr. Danielle Martin this morning, I think we should think about transformation and system transformation and how can these very innovative initiatives that you'll hear about be taken to scale. And starting with spread, but be taken to scale and really transform the system. And in our discussion, both with the panel and amongst the audience, to think about how can we get there. So it's my pleasure to introduce your panelists for this session. Each panelist is going to speak for 10 minutes, and followed by a panel discussion and then audience question and answer. I'm just going to give you the top line of their biographies, which are available to you. So Dr. Noah Ivers, who's immediately to my right, is a scientist at Women's College Research Institute and a family physician at Women's College Hospital, and an adjunct scientist at ISIS. And his research focus includes the use of data to drive evidence-based and patient-centered care, including performance feedback to health professionals and tailored reminders to patients. Dr. Sean Blaine, who's to the right of Noah, is the founder and lead physician of the STAR Family Health Team in Stratford, Ontario. And he was previously Chief of Medicine at Stratford General Hospital and currently Vice President of the Association of Family Health Teams of Ontario. Dr. Rick Glazier is a family physician and senior scientist and program lead of primary care and population health at ISIS, a staff physician at St. Michael's Hospital, and a scientist at St. Michael's Center for Research on Inner City Health. And he is president of the North American Primary Care Research Group. This panel has no relationships with commercial interest to disclose, and it was not a recipient of commercial support. So what is audit and feedback? This is drawing on Noah Ivers' work from 2012, a Cochrane systematic review, and this is a quick overview of what that work looked at. So audit and feedback is a widely used strategy to improve professional practice, either on its own or in combination with a diversity of quality improvement supports and interventions. And the underlying assumption is that healthcare providers are motivated to engage in practice improvement when they see data that may show that their practice is suboptimal compared to desired performance. And does it work? The big question. We're lucky enough to have Noah here who can answer this question in detail. The short version is that audit and feedback practices have been associated with small but potentially important improvements in practice. This is a picture of the desired chain of events, from having access to data to improving practice. The monitoring of performance through audit and feedback is about identifying gaps between current and desired performance, and then making it available at a level that is granular enough to be meaningful and actionable by the recipient of that data. And when those gaps in care are identified, they can then be validated by that recipient in their practice and potentially become the focus of quality improvement efforts in that practice, and ultimately alter the care that patients receive for the better. To start off our presentations, here's an overview of the audit and feedback initiatives that are available to primary care providers in Ontario. There are 6 initiatives listed here, and you will get more detail of each of these that will be sprinkled throughout the presentations this morning. You see Health Quality Ontario's practice reports in primary care and long-term care, the Canadian Primary Care Sentinel Surveillance Network, otherwise known as CIPSEN, Cancer Care Ontario's Screening Activity Report, the Community Health Centre Practice Profiles, the Data to Decision, or D2D, reports that were created by AFTO, and then the Emerald Sapphire program. And the 6 initiatives highlighted here rely on administrative data, or EMR data, with the exception of D2D, which is a combination of administrative data, survey data, and EMR data. And while the Screening Activity Report is focused on a particular type of chronic disease management or screening, it's the screening activity specific to cancer screening, the rest of these reporting tools are about a broader view of chronic disease management and healthcare utilization. I'm just going to show you one example, because as I said, you will hear about many of the examples in the presentations. So these are the dashboards for Health Quality Ontario's long-term care practice report and the primary care practice report. The one on the left is the primary care practice report dashboard, and the one on the right is the long-term care practice report dashboard. And these are a combination of practice demographics and case mix, and service utilization, whether it's admissions or ED visits, as well as chronic disease prevention and management relative to targets, and also looking at the health status of the practice population. And when recipients receive these practice reports, they can see how their performance compares to other practices in the region and in the province. So I'm going to turn it over now to Dr. Ivers for his presentation. You don't need to.
Great. I'll just stay in my comfy chair. Let's see. I wanted to just first and foremost flip back to this cycle that Anna was talking about and just sort of describe this basically as an amalgamation of all sorts of psychological theory and research that's gone into understanding how data can eventually somehow, some way lead to changes in patient care. And I think what typically happens, and we've certainly all experienced this as human beings, this is not a physician or healthcare provider thing, this is a human being thing, I think, that when you get data that says that you're not doing so great, the first thing that you do is you say something along the lines of, the data's no good, or my circumstance is different. Healthcare providers say something along the lines of, my patients are different. And as a result, they implicitly invalidate the data, which makes things much easier for them because they don't have to go do the hard work of changing their practice. And so well-designed feedback sort of predicts this kind of response and prevents it, enabling recipients to go through the full cycle and hopefully benefit their patients. So I was asked to talk about an example where that actually worked for me as a provider, and then we'll cover a little bit around the evidence as well that Anna alluded to. This is a screenshot of the data that you get if you sign up as a family doctor to get data from ISIS and their team called Emerald. And this is the Sapphire is an acronym that stands for the System for Audit and Feedback to Improve Care. It's a messy acronym, but that's the idea. So what you see here is that your performance, actually specifically my performance, is compared to the performance of top peers when it comes to diabetes management. You can see that there's tabs to choose other conditions as well, so you can see how you're doing on an aggregate level. And if you don't tend to think that way, then you can flip the way the data is presented to see not are you meeting all the optimal characteristics or indicators for your patient care, but in fact, what proportion of patients are you actually allowing to be at high risk? And this is probably more akin to, there's a reason we made that red. Many physicians in particular think that way, think about putting out fires before they think about quality improvement. And then the other feature of the Emerald system is that it has patient-specific data. And this screenshot, if it was live, you would see it would scroll and scroll and scroll, showing all the quality indicators patient by patient with each patient on a row. And so the idea being that you can either review it there or call it up in your EMR using the patient ID number and go ahead and purposefully validate that indeed this is a patient that needs action. And so yes, I'll call them in and review them. And it may very well be the case that there's a good reason you're not hitting targets, but at the very least you can see when you get into the details that, yeah, they're not hitting targets, and also I haven't seen them in 18 months, so we should probably bring them in. This is a similar sort of idea. And again, you have the color coding, the red, the yellow, the green. This is my report from not that long ago when it comes to cancer screening. You can see I'm good at some things, not so good at other things. Frankly, the data is not so good for some of those things, so I think we're all right. And like the Emerald report, I have the opportunity to dig in deep and look at patient-specific data and identify reasons why I might be overdue for some patients. Maybe I didn't do their pap smear because they had a hysterectomy, maybe because they're palliative or some other good reason. And for those for whom we've just lost them, we call them in and we get up to date. And my typical practice is to review the screening activity report every December. And so every December, a few dozen of my patients get a phone call from my nurse or a letter if they can't reach the patient saying, we've been going through the data at our year-end audits and we see that you're due. Can we book you something for January or February? And that's basically the very specific process for me. What that highlights, though, is that it's a very clinical process. It's not actually what I would call a quality improvement process. It doesn't change in a proactive way going forward how I manage my clinic. But because I have that patient-specific data, I can take clinical action. That works for me as a clinician, but not necessarily for my management or administrators of my clinic. And that's something worth thinking about. So Anna suggested that this kind of thing works. And I think we have really good data to suggest that some of the time it does, and other times not so well. We did, as was mentioned, a Cochrane review. We had 140 randomized trials of audit and feedback that we found. And overall, you get an improvement in desired outcome of about 4%, which sounds fairly measly. But if the audit's cheap, that's probably worthwhile. But the other thing that's noteworthy is that in about a quarter of the studies, we found a 16% performance improvement, which is quite a lot when it comes to quality improvement, especially with, as I said, a cheap intervention. We identified some characteristics of audit and feedback that results in greater performance improvement. So when the baseline performance is low, in other words, when there's more room to improve, when you have some trusted source involved, so it's not coming from some anonymous research team, but from somebody that helps support you along the way, and ideally somebody that talks to you about the data, and when there's cycles of data. So if you get it just once, we see from the literature that's not nearly as effective as when you know you're going to be measured again, and you better get on top of this because it's not nice when your report card doesn't improve. And then importantly, and going back to this idea that somebody maybe should talk to you, is the idea that there needs to be an action plan. I think, in my mind, data is the foundation for quality improvement, but it doesn't get you all that far if you don't know what to do with it. Certainly, some targeted behaviors are easier to improve than others. But what we found in the literature in general is that most of the programs in Ontario and elsewhere in the world fail to incorporate best practices in a consistent way when it comes to these kinds of practice reports. And we could probably push the field further. We could do better if we had a concerted effort about it. So why is that? Well, I think a lot of it comes down to thinking carefully about how the recipient is going to feel and what exactly we want them to do with the data. And I think frequently, too often, we give data and sort of hope for the best. And in the best case scenarios, we do quite the opposite. We start with the outcome. We start thinking, what is it that needs to change? And we move backwards to create the report accordingly. An example, in 2001, there was published a study where in feedback reports, participants either were compared to the average score of all their peers, or they were compared to the top performers of all their peers. And you can imagine if you're slightly above average and you get compared to the average, you're very, very happy. And if you're slightly above average and you're compared to the 90th percentile, the top ranking peers, you feel like you have room to grow. And so these quite intuitive ideas can be implemented to get a more meaningful and impactful report card. So I just want to come back to that cycle. And if we're thinking through what can push people through the cycle, what can stop them from saying, no, that data's no good, no, my patients are different, or what have you, we need to think about the components of the intervention, like what comparator we use, what's in the content, what's the behavior we're trying to change. And we need to think about the setting as well, the context. So, who are we talking to? How chaotic is their environment? What sort of co-interventions do we need to address the barriers for them to improve? And then we'll have, an ideal sort of practice report that leads to the kind of change that we'd hope for. I'm going to skip one slide, and just because I'm low on time, I'm going to talk about what I fear is going on in the sort of field right now is a lot of overlap focusing on things that are fairly easy to measure. And so, as Anna suggested, we have a lot of chronic disease measurement, a lot of diabetes, as is highlighted on this screen, a lot of cancer screening, overlap with multiple approaches to measuring that. And we know that when it comes to quality improvement, or quality in healthcare in general, there's many, many more domains than just the effectiveness domain. And while we certainly have room for improvement in the effectiveness domain, I think if you go and talk to primary care providers, you hear very clearly that there's more to their job than reaching some target. And we need to think about that carefully and think about how we can, in the very long run, incorporate many other kinds of measures that better reflects the totality of the primary care provider's job. So I'll end on this slide. So, and it just sort of alludes to a large project that we're embarking upon with HQO, where we want to take the practice reports that you saw earlier and try to systematically understand how to improve upon them. So effectively, if we can come up with a better way of delivering the reports that makes it easier for the recipients to do better for their patients, and we test that against how well the first reports were doing, and we see that it is indeed better, that can become the new standard. And we can do that sequentially in a scientific manner. And in doing so, we can hopefully improve care that's provided to patients throughout the province, but also sort of contribute to the science of how do we all do this better when we're thinking about auditing data and providing it back in a way that makes a difference. So I'm happy to address any questions that arise, but I'm sure that I'm out of time.
Okay, can everyone hear me? All right. So I'm sitting in for someone else who was supposed to be speaking to you today, and that was Monique Hancock, who is the executive director at the family health team where I work in Stratford. And so I stepped in kind of last minute for some family reasons. And but I think the fact that I'm able to be here speaks to what I feel very fortunate exists in my own team, and that is a very close working relationship with our administration. I think it's important to know who's speaking to you, and I consider myself one of the haves. And in this province in primary care, we have the haves and we have the have-nots. And I'm very, very fortunate that I'm part of a family health team and that I'm supported by a great association which is doing very exciting work, and that we've had the ability to kind of begin this journey of measurement. It's overwhelming, the amount of information, the amount of data that is out there that gets thrown at us. My own team had the a chance to work with Noah a number of years back on a project that he was working on with some of the Emerald data, and it's great to see this. But 5 years ago, I was kind of a newbie at this. I still consider myself a newbie. When people talked about quality, my eyes kind of glazed over. What does that mean? But I kind of get it now, and I've kind of drank the Kool-Aid, and so it's very cool to be part of this. And really, I think if you look at your own organization and say, well, where are we going with this? It's ultimately to improve the care that we provide. So what are some success stories? Well, as a family health team, we've had to submit quality improvement plans to HQO every year for the past number of years. And wow, to get that information back and to look at it is quite impressive. We are all somewhat competitive as physicians. When my own team has 3 different clinics, 12 different doctors spread out across, and everybody's name was anonymized, and you could tell some clinics were really good at same-day, next-day appointments, others weren't. By the way, I have to just poke a little bit of fun at the organizers. I'm sure it's not your fault, but this is, I don't know if you can see this. This is a panorama of the lineup this morning to get a badge. And it reminds me of the good old fee-for-service days 18 years ago when I started, and that's how long patients waited to get an appointment. But no, we have adjusted how we work based on the information from those QIPs. It is very real, it is very powerful, and we have made staffing decisions based on some of the information that has come back in those reports based on patient feedback. We have one example of a physician at a clinic who really took to heart the complaints regarding delays and chronic lateness, and there were some very impressive administrative and scheduling changes that were made as a result of that. The other thing that we looked at was ED use, and we just took this on our own because while we're talking about this stuff, you ask questions and, gee, well, I wonder why this, I wonder why that. So we took it upon ourselves to look at emergency department use for low priority cases. And because the ministry asked us in our annual plans, they said, well, are you redirecting patients to the emergency department? And so as part of our discussions of the QIPs, we said, well, hey, why are people going? And so we took an initiative to just start calling people once they had gone to the emergency department. Did you know we have to have an after-hours clinic? Did you know when it's open? Did you know that you can be seen the same or next day if you call? And so now we are advertising our after-hours clinic times throughout the clinics and on the TV screens and computers. And we've been able to reduce our ED visits by about 10%. The other success story, I think, speaks to the communication, and we have just, it just kind of happened. I don't know, we talk about quality at every opportunity we can. So we make it the first agenda item on every staff meeting that we have. We have very involved physicians on our team who participate in the quality committee. We have one representative physician from each clinic participating in that. We discuss it at our regular board meetings. And so I think building that culture of quality is one tremendous success that I have seen from that has come out of this. It's important for the EMR to be able to be accessible by all staff on the team, and you'd think that would be intuitive, but in fact some of the D2D data that just came out showed that still right now there's 10% of family health teams where the only person who has access to the EMR data is the physician. Oh my goodness, can't believe that. And 60% of teams have it where there's only some providers and not all. So we've just ensured that all of our staff have access to the EMR, and I think that is important to be able to answer the questions that are important. Again, being one of the haves, we have accessibility to the QIDS support people, the quality improvement specialists that we now are able to help us do this, this type of work and answer the questions that we have. So really, I think the slide speaks for itself. I mean, the importance is knowing where you stand relative to your peers. In my neighborhood, we have 9 family health teams in 2 counties that share one of these quality decision support specialists. And you know, these teams have had some early relationships that were built a number of years ago when the executive directors started talking about, you know, common things like, you know, the budget and ministry type issues. But it gradually evolved so that for the past 2 years, those 9 family health teams are sharing this quality person. We were able to actually have a meeting of a number of physician representatives from all those 9 family health teams. Who would have thought that would have ever happened years ago? And we now have aligned all of our quality improvement plans. So you have a region where 9 family health teams have chosen to align their quality improvement plans because there's more power in collaborating and seeing how not only do I stack up against the doctors in my clinic and against the other clinics in my team, but now I'm going to be able to see how I stack up against my neighboring teams in the town that's, you know, 25 kilometers away. So very, very cool work, and we feel very fortunate to be able to do this work. I want to touch on the work that's being done by AFTO. Our organization made a very concerted effort a number of years ago to take on the issue of measurement. And we felt that it was very necessary, as Noah has alluded to. There's a number of initiatives that are underway across the province. The HQO's primary care framework has gazillions of indicators. So AFTO said, well, how do we do this for our membership in primary care? And we wanted to focus on the 3 M's. It had to be meaningful, measurable, and manageable. And so that's what we've done, is to focus on that. And you can see how for some of these indicators, how we compare to other sources of data. And there are several iterations of the D2D project which are coming out, and I encourage you to go to the website and to talk to our staff about that. Very, very exciting work that's being done. You saw probably that the data that D2D accesses includes both the large data sets, but also patient information from the quality improvement plans, as well as EMR. That's a tremendously rich source. And we have been able to look at our quality by developing this kind of composite indicator, which kind of rolls up a number of measures into one number. And the cool thing about that is that we've partnered with Patients Canada to weight it towards patients' preferences. And so we're very excited about the work that's being done there. And some early work is showing that there's a great relationship with quality and cost, an inverse relationship. And we'll see whether there's causality with that. And we can talk about that later. Again, there's many, many sources of reports. I think there's tremendous richness in the different sources of data. We will continue to work at AFTO looking at the work with family health teams. And now that this process has begun, I think family health teams themselves will begin to ask the questions themselves. And I don't think we should stifle work that's being done in other places just to create one aligned report, because I think there's tremendous richness that can be shared across all sectors. So again, these success factors, I think there has to be engagement from providers, endorsement of associations, competition, peer-to-peer influence is good, champions are good, and I'll just leave it there. It's really just the beginning. We're a long way from the end of this process, but it's very, very exciting, and we're certainly happy to be a part of it. Thank you.
Okay, well, just get to the next. There we go. I want to start by thanking the organizers for inviting me to participate. It's a real privilege to be here, and I'm familiar with our panel members who I've known and worked with for a long time, very close collaborators. Also, I've been very privileged in my role, through my role at ISIS, in being involved with many of these activities. A lot of activity with Health Quality Ontario. I think I've spent more time at HQO with Gail and Wissam and colleagues than I have in any other kind of non-core work setting. Lots and lots of time with AFTO. Real privilege to have served on the board for a while and to continue with being very involved with quality improvement activities. And I spent a lot of time in the AFTO boardroom as well. AOHC, the Association of Ontario Health Centres, is a really important partner, and we've managed to get EMR data from Ontario's 75 community health centres, and we're working that into the profiles as well. So just from my own perspective, very, very privileged to have worked with these tremendous partners on all these kinds of activities. What I'd like to do, and I think Noah and Sean have set this up absolutely beautifully for me, so thank you very much. I want to try to pull things together a bit and set the stage for some conversations that we're going to have as a panel and with you about where's this all going and how do we work together to make that happen and to make it work for healthcare and primary healthcare in Ontario. So I'm going to talk about successes, challenges, and new directions. So, and I'll start with and end on very optimistic notes, very positive notes. And then in the middle of the sandwich, there's going to be some stuff that's a little bit ugly still. And both speakers have, all three previous speakers have alluded to some of the messiness that occurs in the middle there. But I'm going to start with some successes, and I'm going to focus on both the success in measuring things and the success in making things better, because measurement for its own sake is not worthwhile, but you have to measure to manage, as we heard at our plenary. So, but it's not enough. So in terms of measurement capacity, administrative data profiles through HQO are now available for every practice in Ontario. Every family physician, every community health center, every family health team can now access its profile online. That's unbelievable. That's like there are 11,000 physicians that can access their profile, and all of our teams can access their profiles. And we're working with the nurse practitioner-led clinics. We're working with the Aboriginal Health Access Centres to make sure that it's every team in Ontario. It's not yet every team, but it's certainly almost the majority. It's far the majority, almost all. We know that in addition to those profiles, and that CCO does the same thing for every physician, they can get their cancer screening profile. Some practices, particularly the family health teams, CHCs, NPLCs, have practice survey data, and Sean has alluded to that, which is tremendous because we're missing in these large data sets for the province the patient experience. And we heard at our plenary just how important understanding the patient experience and incorporating that into our quality measures is and in our improvement. We know that EMR data can be extracted both locally by practices, not all practices, but by some practices to help with their quality improvement. But we also know that we have systems across the province that extract EMR data and feed it back, and you've heard about both of those. So the Emerald system, the Emerald Sapphire system, and the Sipson system are both tremendous systems that will come to your practice, extract your EMR data, and give you regular web-based feedback that can even be right down to the patient level. So these are major advances. And then we also have provincial and LHIN level data on through the Healthcare Experience Survey. It was formerly called the Primary Care Access Survey. It's now called the Healthcare Experience Survey. That can't really yet go below the LHIN level, but can be done for LHINs and for the whole province, and can actually now be linked with administrative data. So we're finding some very, very interesting things through those linkages. So those are advances in measurement capacity, none of which existed 5 years ago. We know that primary care is a kind of very vast, very frontier, very individualistic, often enterprise. And measuring this thing is a pretty big deal. And it's unthinkable that we would have had this degree of measurement capacity even a few years ago. There have been improvements in care that have been absolutely remarkable. And we've already heard about many of them at the plenary and from the other speakers. But when I go to places like the AFTO conference and look at the Bright Lights Awards winners, or this conference and look at the posters, or go to any of our professional meetings, there have been amazing quality quality efforts in many practices. So just to give you some examples, Ontario's community health centres have by far the highest rate of pap smear screening without adjusting for how sick or rural or anything else their patients are. They have the most difficult patients and the highest rates of cancer screening in the province. And that's through a decade of concerted effort. It's an unbelievable, huge effort. And so that's an example. The AFTO Bright Lights Awards, they're just incredibly inspiring stories. I mean, Sean told one about reducing emergency department visits. I remember another in COPD about reducing emergency department visits by 30%, hospitalizations by 10% through a COPD, very, very focused, important initiative. And these stories are by the dozens in Ontario. We have dedicated QI personnel called QIDs that we've heard about already in some practices, and Sean talked about that. And evidence of broad quality improvement over time. When you look at the massive increase in colorectal cancer screening, it's gone from 20% to about 65% in a period of only about 6 years in Ontario. Like, incredible success story, unbelievable. Diabetes care keeps improving, other forms of care keep improving over time. Very remarkable stories. However, we face a number of challenges. So as has already been alluded to, and Sean had this on one of his last slides, is that our quality improvement data, our measurement data, are fragmented by organization and by data source. There's a large effort required to get this data, extracting data from EMRs, doing practice-based surveys, even pulling together the administrative data, because I have some responsibility for that. These are huge, huge efforts that we mount in order to do this. So far, there's not been, not every family health team is participating in D2D. A minority of Ontario primary care physicians are participating in the profiles, even though they're available to them. So the uptake is not always that high. The picture that we have is incomplete. We don't have all the pieces. We're missing a lot of the important patient-level data across all of our practices, for example. We don't really have fixed targets or benchmarks. We've shied away from that in primary care, but as Noah has alluded to, you have to have a target to aim towards. You have to know where the best practices are, or even where the international best practices are, to know how you're doing. And it's often been very hard to compare with others. That's been built into all these systems, but it's not always easy to figure out, how do I compare with people who are actually like me, who are my peers. Not that they're in downtown Toronto if I'm, in Stratford. That's not an appropriate comparison. I need to be able to compare myself with my peers. The improvements that we've seen in this area of challenges, I'm not going to dwell on this too much, but we've not seen improvements in timely access to care in Ontario. We've had a massive investment in primary care health system transformation, and I'm in favor of all those things. I'm going on record, moving physicians off fee-for-service, building interprofessional teams. These are all fantastic things that we've done. We've spent a lot of money doing this for the last number of years. Timely access to care has not changed. So you can see on the graph, emergency department visits per person have not gone down. Walk-in clinic usage rates have not gone down. Same day, next day access to care has not gone down. None of these have improved over the measurable time period of really close to the last decade, despite all of these investments. So we have challenges. We know that right now, value and sustainability of our models is being questioned. We have this managed access now to capitation, which means we also have managed access to family health teams. And none of us anticipated that this would ever happen, because the value proposition is being questioned. And many of us will question that questioning of the value proposition, but nonetheless, that's a challenge right now, right? That's a big issue right now. And then we have large variability in access and quality across doctors and across practices. So how about positive stuff now? Where will we go with our new directions? How will we be better? What might the future look like? And what might we all talk about together for the next little while? So measurement capacity about extracting and reporting all EMR data. That would be for the whole province. This is already done in other places in the world. The UK, Netherlands, elsewhere, they extract all of the EMR data. That occurs in many places in the world. We're still very, very patchy. Linking with administrative data and survey data on every practice. not making people go to a website and do a fancy login, but having it pushed out to practices, obviously with their consent, but making sure that it goes to them. Area level public reporting, benchmarks and targets. I don't mean each doctor or each patient, but at an area level, all the practices to have some responsibility and accountabilities, and a focus on population health and patient experiences, not just each patient who's sitting in front of you, which is how we're trained, but we need to take on more population approach. So the improvements that I would envision is that every practice has a QI plan, there are individualized targets, supports are readily available, and providers and patients are fully engaged. So I would see a future state of practice. So this is the sign, the direction to utopia, is a dashboard for every practice with timely updates, daily or weekly, quality measures to include patient, provider, policy perspectives, including summary measures of quality, capacity, and cost. So we heard Sean talk about the roll-up, the one number. So it's obviously one number isn't going to tell you where to improve, but you can dig down into that one number and say, how do I compare with my peers, and what are the things that I need to improve? Also our capacity and the cost of our care so that we can complete the triple aim. We need this to be on every practice desktop, publicly reported for areas, easy to see progress towards topics. We need a gas gauge that says, okay, how much improvement have we had? Again, quality supports in every local area, engagement with local providers, meeting population needs, and able to demonstrate contribution to health and to health care system. So that's all that I had, and I look forward to our discussion and discussing all these issues with you, both the challenges and the ways forward, the solutions.
Fantastic, thank you. So I'll start off with a question and then we'll open it up. So we have talked about some pretty significant challenges, but we've also talked, and I think that Dr. Glaser, you've pointed out an unprecedented measurement capacity advancement that I think we should be proud of. If we take what's available now and we look at the fact that we have low uptake, what would be each of your recommendations for what we might do to increase that uptake? So let's start with Noah.
Barring the idea that there's reason to believe that it shouldn't really be an option or a voluntary thing. I mean, you're managing healthcare. At least your aggregate data maybe should just be pushed to you. Full stop. That doesn't necessarily solve the issue of engaging with the data. So even if we accomplished, perfect, complete measurement, we still have the problem of sort of helping people understand that knowing where they stand can help them do better for their patients. So I think that comes down to the content within it. Mm-hmm. And I think we have to choose the right measures that are meaningful, but measures that we can also make a difference in, that we feel as a provider we have the self-efficacy, the resources at hand, et cetera, to do better, and then measure it again and provide it back to me in a time frame where I can see sort of the fruits of my labor, as it were, so that observability of the intervention. So I think in large part it comes down to what we're choosing to measure and how quickly we can cycle it back through. That's going to help build the engagement.
Terrific.
So how to build the uptake? We're seeing it already. In the work that's being done through AFDO and the family health teams, D2D's first iteration, 1.0, had I think maybe 20% of family health teams participating data. And we heard from our members, there's suspicion, there's fear, there's the unknown. What's this all about? What are you going to do with the information? In the next iteration, 2.0, we had over 100 teams of the 185 participating. And I think that speaks to understanding the power of the information. And I think if we just shout out some of the victories to our peers, there will be uptake. I mean, how did I know that one of the people at the front of my office was saying something to a patient until it looked me and I could read it on the piece of paper? And we had suspicions about someone that needed to do something else, and they're now doing something else, and they're not working in the office anymore. So we have to talk about this, and we have to say what the power is. There will be some embarrassment. There will be groups and physicians who will look at the information that comes back, and it will be surprising to them, and it will be shocking to them. And I think we have to be careful how we spread this, because it has to be done in a facilitating manner. What can we do to help you achieve some of these targets, and not in a punitive manner? So I think if people can be assured of that, I think it will flow naturally.
Great.
So I agree completely with the previous comments. My own story is that the community health centers that had historically not had measurement or data very much, we did a little pilot with them about 4 or 5 years ago, with just 6 community health centers, where we brought in their data and we linked it and we fed it back to them. And they started sharing it with the other community health centers. And the next year when we went to do it again, all 75 were in. There were no exceptions across the province. They all, and now, like the problems that we have is, why are the data not up to date? Why didn't we get them last week? Why did, it's like the demand is now turned 180 degrees, and the use of data and the culture change that's occurred in that sector is remarkable and dramatic. And part of it is that they've got accountability agreements for which they need these sorts of data. And a part of it is a legitimate interest in and celebration of the quality improvement activities that they've been undertaking. Much of the rest of primary care is less organized, and I think directing our attention towards the FIGs and the FINs and the FOs that are not part of an organized system, even building in, and that requires lots of culture change. I think working with patients to say these measures are meaningful and important. I think working with areas, I think it's not such a big secret that Ontario is likely going to be establishing regions for primary care, or neighborhoods, health neighborhoods, rather than just medical homes, like a neighborhood that you'll work in as a primary care doctor and a primary care team. And that measurement at that level is probably going to be more engaging than necessarily giving each particular physician or each particular team their things, because they're going to be contributing to that. Then they'll be able to go back and say, what role am I playing in this larger thing? Instituting quality improvement plans for all of those other aspects of primary care will be challenging, but I think really quite important, and having some accountabilities for the neighborhood or region should help to move that measurement along and the uptake along. Again, measurement having to be stuff that's meaningful to people, having to be done in a supportive and not punitive and not threatening way.
Thank you. So does anybody have any questions? And I'd just ask you to use the microphone as this is being recorded. Thank you, Angie.
Oh.
Sure.
Okay. I'm Angie Hayden. I'm Chief Executive Officer of the Association of Family Health Teams of Ontario, which we've been doing a lot of this work. And of course, we've asked a lot of the questions. And the one thing, just listening to your answers right now, I couldn't help but think of Danielle Martin's presentation this morning, and thinking about spread versus scale. And so the strategy that we've been using as an association is because it's an association of members. I mean, our whole reason for being is to help our members, support our members to do things. So it's been very purely a spread strategy of getting people excited about it, seeing the value, and being very engaged in it. One of the scale issues, though, that we had to deal with was just having, it was the making it easy enough to do. I remember Danielle talking about that. If you want to spread something, it's got to be easy to do. One of the key differences that was made was that people spoke about the quality improvement decision support specialists. Now, and I love Sean said there's haves and have-nots. There's not a lot of them. There's only 35 of these folks. across the province supporting 184 family health teams. But that in and of itself was a key factor, I believe personally, to helping make this whole thing be enabled. So the question that I have for the group here is, the world of family, if you put family health teams, CHCs, AHACs, and NPLCs all together, because they have some capacity to make something happen, you're still looking at about 25 to 30% of all primary care in Ontario. If we're going to go beyond that group, which is really, that's close to 3/4 of the population. If you think about spread strategies and scale strategies, do you have any thoughts about what needs to happen? Thank you.
I can take a stab to start. So you don't need to reinvent the wheel every time. So when we hired Matt, who is our quids guy, he had to learn 9 different cultures of these different teams, figure out who the champions were with these different teams. He had about 3 different EMRs to have to work with. But as time goes on, these quids, talk to each other. They learn about quick tricks, and they're pretty innovative. So there is a neighboring foe in my neighborhood, which is not part of the FIT, but they use the same EMR that I'm on, TELUS Practice Solutions. And so a lot of the nifty dashboard work and tricks and algorithms that Matt has already developed for Practice Solutions can easily be adopted in this foe if they were to choose to be interested in doing this type of work. So that's one way. There is no doubt in my mind, though, that we really are turning the health system on its head. And if you're going to do that, there has to be resourcing appropriately. I know people talk, well, we don't need more money, we don't need more money in the system. That's right, we don't need more money, but we need to take money from where it is currently in the system and put it to other places in the system. So if we're moving from a hospital-based acute care sickness system to a primary care, community, chronic care, preventive system, you're going to have to shift those resources, okay? And so, yeah, we are going to need more data support. We are going to have to look at investing in mechanisms to bring in those 75% of primary care groups that currently are not part of an interdisciplinary team. We in the haves will be able, I think, to share the resourcing that we have and the expertise that we have. But there will be, you're going to need to reallocate resources to make this work, because it is a profound change in the way healthcare is delivered. And to think it can be done without that is absolute folly, in my opinion.
Further comment before the next question?
I would just certainly agree with what Sean said. We've got kind of a massive culture change in order to do any of this. And it has happened in these other sectors, and it's still happening in those sectors. There's still teams not participating in D2D, et cetera. So you have to start with the willing. I don't think this is something that can be imposed. But some of the scale strategies would be to start embedding some expectation and supports for measurement in the FIGs and FOs and FINs that are not part of more organized groups like family health teams or CHCs or NPLCs. So establishing some accountabilities and expectations in those agreements together with the supports to make sure that they happen, starting with the highly motivated kind of early adopter volunteers, making sure that these things are presented widely at conferences that people attend, like the Ontario College of Family Physicians and Family Medicine Forum and other places like that, that are not just for teams and the most highly organized parts, but are for everybody and for all the sectors and throughout nursing and social work and all the professions that are involved. But I think ultimately setting up some structures and processes and expectations and supports and moving gradually is how, and setting up some accountabilities is how this will have to move forward. And when people are incentivized, I think they will do this kind of sharing. They will want each other's dashboards. They will want each other's tools. They will want to share quality improvement decision support specialists and learn how they're doing their work in other places. But it's a big job in a very quite unorganized sector.
Thank you.
My name is David Vincent. I'm a family physician from Brantford, Ontario. I'm a FO lead for a fairly large FO in Brantford, and also HealthLinks lead. My question for you is, I'm going to sort of change topics a little bit, is one of the major issues I've had since we created a FO in 2008 is the state of our governance agreement, which addresses the issue of your flat line about after-hours care and the lack of diversion from emerge, one of the many issues. And I wonder if you would see it as a quality improvement to actually look at that governance agreement that exists mainly in FOs and capitated models, to somehow bring a resource of best practices for governance agreements for physicians in capitated type models, as we will be in some sort of capitated model supposedly going forward, if you believe the Price report is the future of Ontario and primary care. I've spoken to other larger FOs and some family health teams, and everyone struggles with these issues. It's kind of getting physicians to do what needs to be done, and there's not a lot of teeth in them. And I know it's partly a legal issue, but we can't seem to find any guidance, and the OMA has been kind of hands-off. They created a template 7 years ago. The government had a template, and to my knowledge, it hasn't been adjusted since then. Do you see any role for HQO to even take that on as a project to look at it and look at other jurisdictions across the world to see how that might be improved?
I mean, I definitely see the content of these agreements as being the role of the ministry for sure. I think that HQO can play a supportive role in terms of what quality improvement tools can enable. I was remiss in not mentioning, for example, in our practice reports, the quality improvement content that is embedded in there. And so our job, I think, is the monitoring and measuring, and also tying our quality improvement supports and resources to that. I see the role of what is in the content of the agreement being potentially aligning with what are considered priority measures from our primary care performance measurement framework, but it is not our role to design those agreements. I don't know if panelists want to make another.
I would just comment that I agree with you. I commonly have patients come in to see me to say, I'm coming to see you because I went to the walk-in clinic and they gave me this prescription and I don't know, and I went on Saturday, and I kind of paused and I said, well, did you know we were open Saturday? In fact, I was on call last Saturday and I could have seen you. And they have no idea. Now, every elevator has got a massive poster. Every wall has got a massive poster that's with the hours, at our different sites, and all day Saturday, half a day Sunday, every evening, Monday to Thursday, and more. We've done surveys. Fewer than half of our patients know that we have after hours, despite these posters and pamphlets just absolutely all over the bloody place. So I think we have an increasing role to make sure that our patients know about those after-hours services and make sure that we are available. I know that we are, and we've been getting busier and busier in those times, and we've expanded those times. But somebody just adhering to the letter of the law doesn't really need to tell. They can have a clinic that they don't really need to tell their patients about, right? And so when Danielle talked about scale, she talked about structures and political will. And some of those things I think do have to happen. So the governance agreements do have to speak to obligations, should have some measurement and accountability, at least for large groups or areas. We'll need to embed some of those things, because simply changing the mechanism of pay shifts some incentives around, but doesn't really incentivize quality improvement per se. And there need to be ways to do that.
So maybe I'll comment on the issue of governance agreements and family health teams, not so much in FOs, but I think there is some analogy here. You know, family health teams do reporting and have been doing reporting for years, but my sense is it's pretty valueless. You know, it's kind of widget counting. You know, how many programs did you run and how many patients did you see, and it's kind of widget counting. I think there would be way more you know, richness in incorporating some of these quality measures into the reporting mechanism, and that could be built into to the governance. Ultimately, organizations really need to go back to their governance principles, and I anticipate that you know, this could be looked at more broadly in the primary care sector. So it certainly is, I guess, an option.
Hi, Jason Bandy. I'm a family doc in Stratford, part of a different family health team. But just wondering what the panel thinks in terms of cause and effect blowback, potential harm from some of these quality initiatives. The slide about screening, you know, kind of increasing while after hours, you know, access has flatlined, same-day access is flatlined, and the government's really hot on same-day access currently, and it's hard not to read something that doesn't have that in mind. To me, that seems to be cause and effect. You know, we've been given incentives through alternate payment plans we get paid a little extra money for trying to get so many people with their pap smears and mammograms and colon screening done. So many of us have been too stupid to actually cost out how much time that takes and staff time and effort to do that, and figure out that financially that probably isn't really worth it. And we've all tried to do that and increased our levels, and the data tends to show that. It takes time, and so it's, and there's not unlimited amount of time. So it's no particular surprise that access is flatlined at the same time as screening has increased, because you don't have time to do everything to some extent. There are access efficiency initiatives that some of us have tried to do and have tried to make that more sustainable, but there's really no end in sight to this ever-increasing ask for people on the ground doing the work. Mostly physicians, and a lot of the work we get asked to do as physicians could be done by somebody else. You know, we're kind of the trained to be the problem solvers. People come in with complex medical problems, and we try to sort out what the best tack is to take, or they've got something they got to get off their chest, whatever. That's our thing. Increasingly, people come in and you're a middle-aged diabetic woman, and my agenda for your visit has 6 things, you know, that I'm supposed to do, you know, before we may even get to what you want me to address. You know, it's not a surprise that there's this blowback. You put resources at some quality improvement thing, and something else has to give because there's just not unlimited time. Partnering for Quality, that I've done a little bit of work with, has this. I'm not sure how many folks are familiar with it. They're trying to improve chronic disease management in the province. So they've backed up a step, saying, well, to be able to do that, you have to have time to do that. In order to do that, you've got to perhaps try to make your practice more efficient. So they're actually helping some of us with that, which seems to be the right way. But you can squeeze a little bit of extra efficiency out of that. But everything we kind of ask people to do, or the government does, or HQO does, these quality improvement plans we do as family health teams, maybe not quite as meaningful as they could be. You know, early days yet, of course, but there's a lot of time, resources, and effort spent doing something that probably doesn't have a lot of, you know, impact to our patients or to our office, or just makes our lives a little more difficult. How do you incorporate the potential cause and effect or blowback from anything you try to do? You know, I'll leave it to you guys.
This is a really great question about competing
There's a
priorities.
Lot. Yeah, that's exactly what there was a lot there, but that's what
it is a
boils down
wonderful
to.
question, and in this context, there have been studies done of what would happen in primary care if we followed all the guidelines, all the chronic disease guidelines, all the screening guidelines. There aren't enough hours in the week to do even the preventive care guidelines for our average panel size of patients, let alone the chronic disease management. So there are competing priorities with our patients, and we have their priorities to deal with as well. We've got our checklist of 6 things we're supposed to do, but the patient in front of us is crying, and the patient in front of us has you know, got a workplace or marital or mental health or family kind of issue And the fact that she needs a pap smear has got to come second, third, fourth, 10th in line compared with a crisis that she happens to be going through or he happens to be going through at the time. The tyranny of measurement can do this to us too. So when you focus on certain things and they're said to be important, I forget who said it. May have been Einstein, may have been somebody else. But the stuff that's easy to measure is often not important, and the stuff that's important is often not very easy to measure. And so we can be seduced into measuring just the easy stuff, and it doesn't mean it's the important stuff. So I think thinking about in our healthcare system, what is the most important thing? So if everybody's really focused on timely access, there are no incentives for that. There actually are financial incentives to send your patient to the emergency department and make sure they don't go to a walk-in clinic so you don't lose your access bonus. I mean, we've structured our incentives in ways that don't make sense. You get paid the same for a sick patient or a healthy patient in capitation of the same age and sex. Does that make a lot of sense? No. So we've got a lot of misaligned incentives. They're talking about modernizing our whole kind of incentive regimen, which is about a decade overdue and desperately needs to be done. But in that work, deciding on what's really important, no matter how hard it is to measure, and some aspects of interprofessional teamwork, some aspects of patient-centeredness are hard to measure, but are really, really important and need to be focused on. So I think this is a fantastic question. It's one of priority setting, one that we need to do as a society. When the Ministry of Health rolled out family health teams, Angie could speak to this, it wasn't exactly so clear what the measurable targets and objectives and outcomes would be. And so AFTO can't jump up and down and say, we've met the criteria you set for us, because guess what? There were no criteria really firmly set, no measurement plan. There wasn't sort of an outline of these are the things we want you to accomplish. And that's the hard work that as a society, Ministry of Health, HQO, all of our professional organizations, it's the hard work we need to do to establish those priorities. Because you're right, when you pay attention to one, something else can easily be neglected.
Not in primary care, so I don't know if this is a good question or not, but you were just talking about competing priorities, and I'm part of a regional screening program, and I'm just wondering how come we don't see nurses doing more jobs that could be delegated to them, like distributing and educating people on colorectal cancer screening, or most people can get a mammogram themselves when they're 50 to 74. Like, how come we don't see more jobs like that delegated when you're right, they're not really needed for someone with more of a problem-solving skill?
So from the perspective of those on teams?
Which we all are.
Well, I think it's a great question. There is no question when you talk about capacity in the healthcare system and in the primary care system, there is tremendous existing capacity to do the amount of work that needs to be done. And in order to access that capacity, you have to have health professionals working to full scope. If you don't have people working to full scope, you're going to have unused capacity in the system, and that's the long and the short of it. So we have a protocol for managing urinary tract infections in my office, which we learned about from some other group that was nearby. And so we took it on, and the nurses now deal with that. And I might be in the room with a patient, and a pop-up comes up that my nurse says, oh, so-and-so's here, this is the dip, and there's no risk factors and no red flags. And I'll just actually prescribe for that other patient while I'm in the room with somebody else. So that I think there is a tremendous unused capacity, and we have to be able to figure out a way to access that, and that's going to be through peer-to-peer spread of some of these best practices. When you look at the data, and as these data sources start to come in and more people participate in D2D, you will see that there are teams that are able to achieve the screening and able to achieve a high score on same-day access and able to achieve other scores and able to have a lower cost score. And it's going to be, why can they do it and this one can't? And that's where the treasure trove is. because they must be able to do something. There must be some trick or algorithm or initiative that they have implemented that is allowing them to achieve those types of measures. And we're only now at the beginning, the ability to look at that and analyze that.
I'll just say that Canada has 3 times as many nurses as it has doctors. And so this is a vast resource that I think I agree that we're not using well. So we don't have good measures in any of our interprofessional settings about what nurses or even nurse practitioners are doing. We don't know we don't know what social workers and pharmacists are doing. We have no encounter-based data. We have a limited pilot of about 30 family health teams where nurse practitioners have been doing some sort of shadow billing, but we have no other idea across our interprofessional teams of what all the interprofessional members are doing, and there are no best practices and there are no standards. So we have no measurements, we have no best practices. Should the pharmacist be doing medication reviews, or should they be running asthma or diabetes groups, or should they be running smoking cessation? We don't know. What should the nurse ideally be doing in an interprofessional team? Now, there should be adaptation to local environments and local needs, but we don't even have a set of best practices for what is the role of the nurse on a family health team, in an interprofessional team, in a FO, in a FIG, in a solo practice. How would you best deploy a nurse? What is the nurse professionally at the top of her or his license able to do? And should they be doing that? We need like a 20-page document every year at my hospital that allows nurses to give flu shots. It's unbelievable. It's absolutely unbelievable, kind of the rigmarole that's involved in something so obvious and within their capacity and license. But those things all need to be negotiated. So setting understanding best practices and making sure everybody's working to the top of their capacity, I think we've got a long way to go for that, for all of our health professionals in Ontario. And it will help physicians to redefine what they do. What is the stuff that doctors do best, and they should be doing that stuff and not the stuff that other health professionals can do best. So, but we're not really, some teams, as Sean has said, have worked that out really well because they've got great people and great direction and great leadership, but we don't really have standards and we don't really have measurement that would help to tell us how we're doing or where we're going.
It's worth thinking about how all these strands of thought tie together, I think. And if we could measure all the domains of quality that matter in a consistent way, and I think all of us now have said that AFTO's approach, the D2D, is the best, the closest thing to that in Ontario that I know of in primary care, and it's something to be very proud of and hopefully spreads. If we can do that, then we still need to adequately support the recipients of that data to do something with it. And those supports could come in the form of governance structures. And if they did, those governance structures need to recognize that many physicians out there, especially physicians not working in a have team, don't have managerial experience, don't have comfort with practicing population health, don't have practice or comfort with standardizing processes in a clinic. That's not what they do. They do patient-centered care for the patient in front of them, and they do make clinical decisions about that patient. So if we're going to restructure governance that addresses what we do with the things we measure, we need to think about specifically the supports that help a clinician, even one that is very good at complex medicine, to decide when does he or she need a nurse, what should that nurse do? When does he or she need a pharmacist? What should that pharmacist do? So on and so forth. Maybe that's sort of how these things come together a little bit.
Well, thank you very much. I take it as a very good sign that a conversation about measurement and tailored reporting uncovers all of these major policy and reform questions in primary care. I think that's exactly what it's designed to do, starting at the practice level, but then thinking quickly to the regional and the provincial level. And I think that is why we measure, and it forces us to think about what are the policy barriers we can remove, how can we get to scale by by making structural change. And I just want to say thank you to this panel. I think it's been an excellent tour across the province and what's going on in personalized reporting. And thank you to the audience as well for your questions.
That's good.
That's great.
Yeah.